Hi, my name is Valerie. I'm a registered nurse and a health educator. On this channel, I try to break down the best available and most recent scientific evidence on health and longevity and present it in a way that's easy to understand and free from hype. The topic of this video is one that is becoming increasingly important in cardiology, but still is not widely known or understood by most people. I knew very little about it until I found out that mine was high just over a year ago. It really is something that is not talked about enough, especially considering that 1 in 5 people will have an elevated level and that it can triple your risk of a heart attack. It is called lipoprotein A, and it is a genetically inherited cholesterol particle that, when elevated, increases the risk of heart attack, stroke, and aortic valve disease. What makes lipoprotein A different from the other cholesterol numbers that you're used to hearing about is that it is largely determined by your genes. Diet and lifestyle have very little effect on it, and many people don't even know their level unless they have had a specific test for it. I know I have a lot of viewers who have found me because they were looking for more information on lipoprotein A. So I wanted to take a deeper dive into the science behind it. But don't worry, I'll be explaining it all in plain, easy to understand language, or at least as easy to understand as I can make it. In this video, I'll be talking about exactly what the lipoprotein A particle is, how your genes influence it, why it is so tricky to manage, and what it actually does in the body to increase cardiovascular risk. I'll also share who should be paying particular attention to their lipoprotein A levels, how testing works, and what can realistically be done about it right now. So, if heart disease runs in your family, or if you have been told you have plaque buildup in your arteries but have no known risk factors, this might be the missing piece of the puzzle. And if you've already been diagnosed with an elevated lipoprotein A, my goal is to help you understand what that means and what the latest science says about how to lower your overall risk. So let's start by talking about what lipoprotein A actually is. Lipoprotein A, sometimes called LP little a, is a type of lipoprotein which is a particle that carries cholesterol and fats through the bloodstream. Structurally, it looks very similar to LDL, or what we call bad cholesterol, but with one key difference. It has an extra protein attached to it called apolipoprotein A, or ApoA. That addition changes everything. ApoA gives lipoprotein A properties that make it more dangerous than regular LDL cholesterol. Not only does it still deliver cholesterol into artery walls, which contributes to plaque buildup, but it also has unique effects that increase inflammation, clotting, and oxidative stress in the blood vessels. Now, just to avoid any confusion, because I know this is a bit confusing, this ApoA protein is not the same as apolipoprotein A1, also known as ApoA1, which I talked about in my last video. ApoA1 is very frequently just referred to as apolipoprotein A, or ApoA. However, its full name is ApoA1, which is completely different. It is found on HDL, or good cholesterol, and it is generally protective. ApoA, on the other hand, is what gives lipoprotein its high risk profile. So I'll be putting a link to that previous video in the description if you want to learn more about ApoA1. But moving forward in this video, when I say ApoA, I am referring to the protein that is attached to lipoprotein A. So this ApoA protein has a very distinctive shape that attaches to the LDL particle, kind of like a tail. This tail contains multiple structures called Kringle 4 repeats, named because they resemble the circular Danish pastry. The number of these Kringle repeats varies from person to person, and that is important because the fewer Kringle repeats you have, the smaller and denser your lipoprotein A particles tend to be, and the higher your lipoprotein A levels usually are. In other words, your lipoprotein A level is mostly determined by how your genes code for this one protein. Unlike LDL cholesterol, lipoprotein A does not change much with diet, exercise, or weight loss. That is because over 90% of your lipoprotein A level is determined by your genes. This is what makes it so unique and also so frustrating. You could be doing everything right for your heart and still have an elevated lipoprotein A due to your genetics. This genetic blueprint, or how your body codes for apolipoprotein A, is why lipoprotein A is so strongly inherited. And it is why levels remain relatively stable throughout life, regardless of your lifestyle choices. What makes this even more difficult is that standard cholesterol panels do not measure lipoprotein A. So you can have a normal cholesterol profile and still have a high lipoprotein A level, and that contributes silently to plaque formation and narrowing of arteries. Lipoprotein A is also a carrier of oxidized phospholipids, which are highly inflammatory and damaging to blood vessels. These oxidized fats may explain why lipoprotein A appears to raise cardiovascular risk independently of other risk factors. In fact, some researchers now believe that oxidized phospholipids may be the most dangerous component of lipoprotein A. As I have already said, lipoprotein A is almost entirely genetically determined. In fact, more than 90% of the variation in lipoprotein A levels between individuals comes down to differences in a single gene, the LPA gene, which encodes or basically provides the genetic instructions for making the ApoA protein. What makes this specific gene interesting and complicated is that it is highly variable. The LPA gene can produce ApoA proteins of vastly different sizes, depending on how many of those Kringle repeats are present. These repeats are like copy and paste loops in the genetic code. Some people have genes that code for many repeats, resulting in larger ApoA proteins that are produced less efficiently. Because they are produced less efficiently, this leads to lower lipoprotein A levels. Others have fewer repeats, making smaller ApoA proteins that can be made more efficiently and therefore in greater quantities. These are the people who tend to have much higher lipoprotein A levels. This variation is inherited, meaning your lipoprotein A level is essentially set by your parents and often runs in families. Meaning, if one or both of your parents have an elevated lipoprotein A, you are more likely to have it too. So, unlike other forms of cholesterol, lipoprotein A is mostly set by your genes, but it's not exactly completely fixed at birth. Studies show that lipoprotein A levels are very low in newborns and gradually rise over the first months and even the first years of life, typically reaching adult levels by around age 2. From there on, your level tends to stay relatively stable. Lipoprotein A levels can vary 1,000-fold within the same population. Some people have levels very close to zero, while others are predestined to have extremely high levels. That wide range is one of the reasons why lipoprotein A can be difficult to study and why it is not yet routinely tested in all clinical settings. There are also important ethnic differences in average lipoprotein A levels. Those of African descent tend to have higher average concentrations compared to those of European descent. Eastern Asian populations generally have lower levels, while South and Western Asian populations fall somewhere in between. However, lipoprotein A is a cardiovascular risk factor in all groups. It's just that the level at which risk becomes significant may depend more on a person's percentile within their population than on any one universal cutoff. So, in other words, lipoprotein A value that is considered moderate in one ethnic group might still reflect high relative risk if it's well above average for that population. Researchers are continuing to study how these variations affect individualized risk assessment and future decisions about treatment. Finally, another emerging area of interest is how lipoprotein A levels might interact with other genes to influence cardiovascular risk. We don't yet know everything about these interactions, but it is an active area of research, and it is helping to shape how we think about personalized cardiovascular prevention in the future. Now, what exactly does this lipoprotein A particle do in the body that makes it so harmful? Lipoprotein A contributes to cardiovascular risk through multiple pathways. First, because it carries cholesterol, just like LDL, it can deposit that cholesterol into the walls of arteries, promoting the buildup of plaque. That alone would be enough to increase cardiovascular risk. But lipoprotein A does not stop there. The ApoA tail, which makes lipoprotein A unique, also gives it pro-inflammatory and prothrombotic properties. Prothrombotic means that it is more likely to cause blood clots to form. Lipoprotein A also carries those oxidized phospholipids, which are highly reactive inflammatory molecules that damage the lining of blood vessels and make existing plaque more likely to rupture. Lipoprotein A also resembles plasminogen, which is a protein involved in breaking down blood clots after they have formed. But unlike plasminogen, ApoA doesn't help dissolve clots. Instead, lipoprotein A interferes with the normal clotting process by competing for the same binding sites on damaged blood vessels or clots. This increases the risk of dangerous clot formation by delaying the body's ability to clear clots efficiently. Clots then form on top of unstable plaque where they can block blood flow to the heart or brain, leading to a heart attack or stroke. Lipoprotein A also plays a role in aortic valve disease, particularly aortic stenosis. The same inflammatory and cholesterol-rich properties that affect arteries may also accelerate calcium buildup in the aortic valve, which can lead to narrowing and stiffness over time. In fact, elevated lipoprotein A is now recognized as one of the strongest genetic risk factors for calcified aortic valve disease. So, in summary, lipoprotein A increases risk not just because of the cholesterol that it carries, but because of the inflammatory, prothrombotic, and calcifying effects that come with the ApoA protein and the oxidized phospholipids that it transports. This multi pronged impact helps explain why people with high levels can face significantly elevated risk, even when their LDL cholesterol is considered normal. Unlike LDL cholesterol, which can respond well to diet, exercise, and medications like statins, lipoprotein A is mostly resistant to lifestyle changes. Eating a heart healthy diet, exercising regularly, and maintaining a healthy weight are all important, but they generally do not directly lower lipoprotein A levels in a meaningful way. And that is because 90% of your lipoprotein A level is determined by genetics, specifically how your body produces that ApoA protein. Unfortunately, there are currently no approved medications approved to specifically lower lipoprotein A. Statins, which are highly effective for lowering LDL cholesterol, have little effect or in some cases might even cause a slight increase in lipoprotein A. That being said, statins still reduce overall cardiovascular risk, even in people with an elevated lipoprotein A. So they can still be a very important part of your treatment plan. Targeted treatments are on the way. I do have a video that goes into greater depth on this, and I will put a link in the video description. But for here, I will mention that several drugs are in development that directly lower lipoprotein A by targeting the production of ApoA in the liver. Two of the most promising therapies are pelacarsen and olpasiran. These are both injectable treatments that use RNA-based technology to silence the gene responsible for making ApoA. Early studies have shown reductions of up to 90% in lipoprotein A levels, which is extremely promising. But these drugs are still in clinical trials and are not yet available for general use. The best strategy is to focus on managing other cardiovascular risk factors aggressively, such as lowering LDL cholesterol through diet and, if necessary, medications, controlling blood pressure, avoiding smoking, staying active, and maintaining a generally heart healthy lifestyle. Even though we cannot lower lipoprotein A directly yet, we can still make a significant difference in overall risk by addressing the factors that we can control. There are also a few supplements that show some potential for lowering lipoprotein A, although the evidence is limited and it varies from person to person. I recently did a deep dive video reviewing what the research actually says, and I'll put a link to that video in a description if you want to learn more. Since lipoprotein A is determined mostly by your genetics, it is generally something that you only need to test once in your life. But knowing that level can be important, especially if you or a family member has experienced heart disease or stroke at a young age, or if there is a history of calcified aortic valve disease. These can sometimes be the first clues that elevated lipoprotein A is playing a role. Several professional organizations now recommend that everyone has their lipoprotein A checked at least once, especially if you have a personal or family history of early cardiovascular events. If you are watching this video and have not had it tested, this is a good reason to go talk to your doctor about it now. So, although lipoprotein A levels are largely stable throughout life and usually being tested once in a lifetime is enough, there are a couple health conditions and life stages that can cause them to rise. These include menopause, chronic kidney disease, nephrotic syndrome, and inflammatory conditions like rheumatoid arthritis or lupus. In situations like these, it might be worth rechecking that level, especially if new risk factors emerge. Elevated lipoprotein A can quietly raise your cardiovascular risk, even if your standard cholesterol numbers look fine. Knowing your number can help guide a more personalized prevention strategy. Testing for lipoprotein A is done with a simple blood test, but interpreting the results can be a bit confusing. And I see that in the comments a lot. And that is because there are two different units of measurement in use. Lipoprotein A can be measured in either milligrams per deciliter and nanomoles per liter. The reason for this has to do with how lipoprotein A is structured. As I talked about earlier, the number of those Kringle repeats in the ApoA tail varies from person to person. That means some particles are heavier than others. So when labs report in milligram per deciliter, they're measuring the mass of the particles. But when they report in nanomoles per liter, they're measuring the number of particles, regardless of their size. This is important because cardiovascular risk seems to be more closely related to how many particles you have, not just how much they weigh. For this reason, many lipid experts prefer results reported in nanomoles per liter, and the two do not directly convert. As far as interpreting the numbers, most guidelines consider a level above 50 milligrams per deciliter or 125 nanomoles per liter to be elevated. But the risk seems to go up even more sharply when levels rise above 180 milligrams per deciliter or 430 nanomoles per liter. These very high levels are associated with significantly increased risk for heart attack, stroke, and aortic valve disease, especially if other risk factors are also present. So if you do get your lipoprotein A tested, be sure to check which unit that your lab is measuring in. And if you are unsure of how to interpret your result, this is definitely something to go over with your healthcare provider or even a lipid specialist, often called a lipidologist. Lipoprotein A is a genetically inherited cholesterol particle that contributes to plaque buildup, inflammation, and clotting. If you have elevated levels, it does increase your risk of heart disease and stroke, but it is important to remember that it is just one risk factor among many. Your overall cardiovascular risk is shaped by a combination of things like LDL cholesterol, blood pressure, blood sugar, metabolic health, smoking status, inflammation, lifestyle, and family history. And even if you cannot change your lipoprotein A level right now, you can reduce your total risk by targeting the factors that you can control. So this means keeping your LDL cholesterol low, staying physically active, eating a heart-healthy, anti-inflammatory diet, managing stress, getting enough sleep, and avoiding tobacco. These all make a real difference, even with the presence of an elevated lipoprotein A. There is also hope on the horizon. New treatments are in clinical trials that specifically target lipoprotein A, and they have shown impressive reductions in early studies. Yet, we still don't know if that actually translates to lower risk, which is what is being studied now. While they are not yet approved, they are getting closer, and I will be sharing updates as that science evolves. In the meantime, if this video helped you, please give it a like and please subscribe and explore my other videos in my Lipoprotein A series. I put a link to the full playlist in the description below, along with a link to get my Tiny Habits for Heart Health guide, which includes realistic research-based strategies to support your heart every day and tips on how to sustainably stick to those habits. You can support my channel and help me make more videos like this possible by hitting the thanks button below or joining my Patreon, where you can get a monthly one-on-one call with me at the highest membership tier. There is a limited number of those available, so if you're interested in that, join today. The free tier membership level will have a concise summary of this video, so at least check that out. Thank you so much for watching, and as always, please take good care of yourself.